well. So I'll have Brianna introduce herself.
Anna, I am also a lactation consultant, and I'm also a sleep consultant as well. So you may, if you haven't already, I teach the Sleep for the Breastfed Baby class. So you might see me at some point in that as well. But yeah, so I basically started my passion with lactation when I had my first child. I have 3 kids, 13, 11, and 8. I breastfed them all for probably too many years that you even want to know about. So probably about 10 years with all of them. So a long time. I've been a lactation consultant since 2015. Basically, once I was, had some kids and was able to kind of focus more, that's when I started my lactation journey. I specialize in infant sleep, of course, back to work, prenatal sessions, so any prenatal breastfeeding sessions, and postpartum as well, and breastfeeding education are my jams. So a little bit of fun fact, I love to play ping pong, and I usually win. So a little fun fact there.
I don't think I've ever played ping pong.
Oh God.
I'll have to try it sometime. All right, so just a couple little things to go over. Like I mentioned, she will be answering all your questions in the chat, but then also if we cannot figure out who you are, then we'll be sending you, or Brianna will be sending you a direct message to see who you are. Please make sure that you do respond to her. We welcome you to have a support person here. If you are a support person, maybe you're logged in as, someone's support person, that is totally fine. Just let us know who you are and who you're here to support. If she does reach out to you, you're not going to get in trouble for being here if you're, trying to take this class to support somebody. Really important. We, as much as I love seeing your faces, we also need your screens on or your cameras on, because insurance requires that we have some face-to-face time. So it is important to put those on. I understand if you're eating or, whatever you're doing, that is okay. But we do ask that you put them on. That would be great. All right. Brianna's also going to drop, we have a resource link. She's going to drop that in the chat in just a second, but we like to get to know who you are. So if you can, just drop in the chat how many weeks pregnant you are. Oh, I don't know why it says that after. Or if you've already had your baby, let us know how old he or she is. A lot of 20 weeks, 30s. Wow, you guys are fast. Trying to keep up with. I see a 38 week, so close. We have some babies that are already here. That's awesome. 18 weeks with twins. That's exciting. All right. And then, is this going to be your first time breastfeeding? A lot of yeses. Awesome. All right. So welcome. If this is your first class, we're happy to have you here. If you have not already taken any other classes, we also have a ton on like just on the calendar. So you can certainly find any one of our educators in any of these classes here. We also have 2 that are not listed on our site, and that's how to create a hospital birth and breastfeeding plan. Those are done as one-on-ones, as well as birth and feeding refresher for baby number 2. We also have a free Zoom link. It is free. It is every Monday at 3 p.m. That's Eastern time. And we do encourage you to come out and, hang out on Zoom with other moms that are also, postpartum, kind of going through the same thing that you are. As I mentioned, Brianna's going to drop that link into our chat. These are specific resources for this class, so you'll be able to get some information. We don't share the slides or recording of the slides, so this is how you're going to get those specific resources from the class we talked about, or that we went over today. These are the topics that we're going to cover today. I'm not going to read them to you. We certainly have quite a bit to get into. So I am going to go ahead and get started. So I'd like to start with the benefits of breastfeeding for your baby. Breastfeeding in general just has immediate and daily benefits. So breast milk itself contains immune factors. Basically, they're customized to the pathogens in your family environment. So like where you live, what things that your babies are exposed to. If you're sick, if somebody else in your home is sick, your body is going to start producing antibodies to that illness, which are then transferred to your baby via your milk. So, this can either prevent your baby from actually getting the germs and getting sick, or in some cases, it'll just lessen the duration or the severity of your baby's, illness or cold, whatever it may be. So essentially, your breast milk is going to act like medicine, in a sense, to help cure or lessen the duration of any sickness with your baby. So in terms of benefits directly for the baby, it will reduce the risk of allergies and asthma, and that's by up to 42%. It also reduces the risk of obesity by up to 30%, reduces the risk of type 1 and type 2 diabetes, reduces the risk of hospitalization for lower respiratory disease by 72%. It reduces the risk of SIDS by 36%, reduces the risk of gastrointestinal infections by 64%. It will reduce the risk of neck or necrotizing enterocolitis, which is a serious GI infection. Usually it just affects preterm babies, but it reduces that by up to 77%, and then reduces the risk of childhood leukemia by up to 20%. But there aren't just benefits for baby. There are also long-term health benefits for mom when breastfeeding is successful. So it will reduce the risk of hypertension and cardiovascular disease when mom has a cumulative lactation history of 12 to 23 months. It'll reduce the risk of type 2 diabetes. For each year of breastfeeding, there was a decreased risk of up to 12%. It also reduces the risk of ovarian cancer by 28% when mom has a cumulative duration of breastfeeding of longer than 12 months. It also reduces the risk of breast cancer by 28%. Same thing when you've been breastfeeding for about a year. It will speed shrink the uterus to pre-pregnancy size, which helps reduce postpartum blood loss. So it's going to shrink that uterus back to the size that it was pre-pregnancy. The faster it does that, the better. And then it will decrease the risk of postpartum depression. I always say that this one's kind of tricky. So it will decrease the risk of postpartum depression if breastfeeding is successful, breastfeeding is going well. It can actually have the opposite effect if breastfeeding is not going as well. It does promote faster weight loss after birth. You could be burning about 500 extra calories per day. All right. So one of my favorite things about breastfeeding, and one of the important things when it comes to being successful in breastfeeding immediately after birth, all comes down to the golden hour, or just getting in as much skin to skin as possible. So typically this will happen immediately after birth for a vaginal birth, providing you and baby are stable. Or as soon as possible after a C-section. If you are unable to do skin to skin, I highly encourage whoever you have as your birthing partner to be willing to do this. It is that important. So during that golden hour, there is direct, immediate skin to skin contact for mom and baby. There is delayed cord clamping. So if you are choosing to have that cord clamping delayed, they will allow that cord to pulse while your baby is doing that skin to skin. Any initial assessments that they're going to do of your baby can be done while you are doing skin to skin. There's no reason for them to whisk the baby away unless there's a medical concern. Then yes, they will. But any of those initial assessments can be done while you're doing this skin to skin, and it makes for early initiation of breastfeeding. So really, when we think about it, if your baby is on your chest, they are already so close to where they need to be to start breastfeeding. So I always encourage moms to start doing some skin to skin, and then you can try to get your baby to latch from there. There are tons of benefits of skin to skin. This is just some of them, really important ones. So any skin contact with mom will help stabilize a newborn. So it helps to stabilize their blood sugar, their temperature, and their heart rate. Super cool. So I know some of you are having twins. I saw that. I used to teach this in the NICU, and I wrote my thesis on skin to skin in college. And so so cool that our bodies are designed to basically, like, let's say we have our twins on our chest. If one baby is too cold and one baby is too warm, our body will regulate both of their temperatures. Like, that's how cool and how important skin to skin is. It will help facilitate mom and newborn bonding. And then uterine contractions from early breastfeeding, it helps the uterus get back to the normal size quicker and decrease the chance of postpartum blood loss. And then it does decrease crying and stress hormones. Your baby can hear you. They can smell you. They know that it's you. They can hear your heartbeat. And so it's going to decrease that overall stress. Birth itself is stressful. So putting that baby skin to skin is going to help sort of get rid of that stress from birth. There was a huge study done in 2015, and it showed that moms who have skin to skin contact experience less anxiety by day 3 postpartum, and are more confident in their parenting abilities at discharge. So in the hospital, just kind of hunker down, do a ton of skin to skin. It's going to, decrease a ton of things, or there's a ton of benefits to it. But then also it's going to help, lessen your anxiety. And, it's going to help you feel better as a parent and feel more confident. All right. So how is milk made? Truly, when it comes down to it, it is supply and demand. I hate making it seem that simple, because certainly there's a lot of parts that do play into it, but truly, the more milk that is removed from the breast, then the more milk you're going to make. On the flip side, the less milk that's removed from the breast, the less milk you're going to make. So, colostrum, we'll talk about that, is sort of like that first milk. You start producing colostrum as early as week 16 of pregnancy. So I think most of you, I maybe saw a couple that weren't quite there yet, but most of you, are already into that, 16th or past that 16th week of pregnancy. So you're already making, colostrum, which is great. So colostrum is like this thick, sticky, often golden color. It is truly all your baby needs in the first few days of life. Your breast will not feel any different immediately after giving birth. Like, it is not, give birth and have, overflowing milk. Your body is going to be producing colostrum. The way I sort of look at it is like, when you buy the laundry detergent and it's like, the concentrated version of the laundry detergent. So you're only supposed to use a really tiny amount. That is how I sort of think of colostrum. So colostrum is like the super concentrated version of breast milk. And so babies do not need a lot. The average in the first couple days is about 1 teaspoon per feeding, and that's for the first 24 hours of life. Colostrum removal is really, really important. It's essential for establishing your milk supply. So most babies will be fully satisfied with just a small amount of colostrum. Again, it is very much like that super concentrated milk. If your baby is having any difficulty latching or is not nursing well, we're going to talk about hand expression, but that is what we would want you to do. So we want you to hand express. It is better than a pump, especially within like the first 48 hours. You get more with hand expression than you do with pumping. And so in that case, you would collect that colostrum and feed it to your baby. And truly, the properties of colostrum cannot be duplicated. I know that, we see it all the time that they try. I always laugh because I have goats and chickens, and we'll go to Tractor Supply and they have like buckets of like, I don't know, maybe it's cow colostrum. It'd be like powdered cow colostrum. And I'm like, how? Like, how did they recreate that? We cannot duplicate the properties of colostrum. It is that important. A breastfed infant will take about, again, 1 teaspoon or a little bit over, so about 6 mLs per feed, and that's in the first 24 hours of life. From there, we have transitional milk. So this is basically the name given to breast milk produced from the time your milk comes in, which is usually around day 3 to 5 after delivery. And then until about 6 weeks postpartum is where this transitional milk is. Um, it's often a little bit more yellow. It could be thick, creamy looking. These are all good signs. And but during this process, so usually between like when the colostrum is there and you're getting that transitional milk, many moms will experience engorgement. Um, and so engorgement is typically, it's short-lived. I would say we don't see it, true engorgement last more than about 2 to 4 days. But basically, it's caused by the beginning of like copious milk production. There's also inflammation of the breast tissue as your body starts to acclimate to this process. The way I sort of think of it is that, your breast and there are all the milk ducts. But at the same time, let's say you've had a ton of fluids during your labor and delivery. Now you have excess blood flow to the area. Um, you have milk that's trying to come in, and then you have, excess fluid in the area as well, and they are all fighting for the same space. So that's what can make it pretty uncomfortable. Your breast can become, you know, large, uncomfortable. Sometimes they're super, super hard. We say that the best way to eliminate or alleviate the engorgement is frequent milk removal. So bringing your baby to breast as often as possible. You can certainly do some breast massage. And that is literally like just gentle, as if you were, I don't know, maybe like rubbing in lotion or I always like maybe like petting a cat or something. But you're just going to be gently massaging that excess fluid away from the nipple to make this area softer for baby to latch onto. You can also try some ibuprofen. You could talk with your healthcare provider about that first. Hot and cold therapy is great. So cold in between feedings will help reduce the inflammation, and then heat just before each feeding to help soften the breast. If that initial engorgement does not subside within like 2 to 4 days, you do want to reach out to a lactation consultant because it could mean a whole host of things, and we want to try to help you alleviate that because it can be uncomfortable. So what we see in this transitional phase is that the volume of milk will gradually increase during this phase. Usually the peak of it is about 40 days or about 6 weeks postpartum. During this time, a breastfed infant will take an average of about 27 mLs, well, 30 mLs is 1 ounce, every feeding by day 3 of life. The volume will increase to about 45 to 60, so about an ounce and a half to 2 ounces every feeding at around 1 week old. And then from 1 month to 6 months of age, a breastfed infant takes about an average about 25 ounces per day. And that looks to be about 2.5 to 5 ounces per feeding. And every baby is different, but the average is about 25 ounces per day. I do want to talk briefly about letdown. So some of you may be able to feel that letdown when it does happen. Basically, what a letdown is what we use to describe the milk ejection reflex. So it does become more noticeable as milk production increases once you're in that transitional milk stage. Some people never feel it, and that's okay. It doesn't have any indication on, breast milk production or anything like that. It's just that some people can feel it and some people can't. Basically, this, your letdown is triggered by the release of oxytocin, which is that love hormone. Sometimes, moms report that there's like a tingling sensation, maybe a feeling of fullness at the nipples, burning, itching. It can just feel like a weird sensation on the breast. Sometimes I just feel heavier. So some moms will leak when a letdown is triggered, but it's also normal not to leak. So there's a whole range of normal when it comes to breastfeeding. So, sometimes you will leak and sometimes you will not. If you do leak, you can certainly collect it. They make milk collectors, not necessarily the Haka. Haka is a pump, but, milk savers or Haka makes one that looks like a little ladybug. You can certainly catch that on the other side. It's also common, so let's just say you could really, really feel your letdown. It is common for the letdown to become less noticeable as your baby gets older. It doesn't mean, again, that there's no milk, it just means that it just becomes less noticeable to you. And then once your milk supply peaks, so at around that 6 week mark, we call your milk mature milk at that point. It is often whiter. It may be thinner. Again, that transitional milk can kind of look, really yellow, kind of thick. Um, but basically, at that 6 weeks postpartum, the initial postpartum hormones begin to level off. And it can be really hard to influence your milk supply at this time. So that is why it is so important in the first 6 weeks postpartum, to work on establishing your milk supply, and making sure that you are removing the milk frequently, so bringing that baby to breast as often as possible. Frequent milk removal is essential for building and maintaining a full milk supply. So that's why if there is anything going on, we do recommend that you reach out sooner rather than later. Just because, again, after that 6 week mark, it's very hard to kind of influence your supply. So if, baby's not removing what they need, and you reach out at that, 5 week mark, it can still be a little bit difficult because when we only have sort of a week to kind of manipulate this. So just keeping that in mind, I would not hold off if you need support. And then with the mature milk, oftentimes, um, we will notice that if you set it on the counter that some of, the fat will kind of come to the top. So if any of you have ever seen like raw milk, we'll see like that fat kind of separates. It's on the top. It is okay to have that. You don't scrape it off or anything like that. You'll just swirl it to kind of combine it. There's no way though to accurately assess fat or calorie content of breast milk just by visually inspecting it. The other thing I see all the time is people saying like, well, I don't have milk that looks like that. So oftentimes we'll see in, Facebook groups where people are showing pictures of like their milk plugs and or their fat plugs, and those are great. But it just means that that's the milk that their baby needs. Not every baby needs that much fat in their milk. So just because you see somebody else's Facebook picture with this, massive amount of fat at the top of their bottle, it does not mean that your baby needs that fat as well. Your body is going to produce the milk that your baby needs. All right. So one of the most important things I can tell you is that breastfeeding should not be painful at all. There's no initiation period. You don't have to just get through the first couple weeks and just kind of suck it up, and then it gets better as it goes on. Breastfeeding absolutely should not hurt at all. I will say there may be some initial discomfort, mostly because we are using one of the most sensitive parts of our body that does not get used, and then all of a sudden is used multiple times per day. Basically, your nipples and your breasts are receiving a ton of stimulation, but it should not be painful. Pain to us is a sign that something is not right about the latch. So I want to show you what it kind of looks like to latch your baby. I'm going to use my little puppet here. Hopefully you can see this okay. I'm actually going to shut off my background just for this. If you need to see me, you can always hit where I am, and then you can pin me. If you hit the 3 little dots, it should say pin, and then that way I will come to the top just for now so you can see what this looks like. And I'll also show you a video in a second as well. So what we're looking for is, we call it an asymmetrical latch, meaning we don't want baby just to come directly onto the breast like this. We want it to be off-centered. So what that looks like is that baby's nose will be opposite of the nipple, and then naturally babies will drop their heads back and they're going to come up and over and onto the breast. And the idea is that we want them to take the nipple, all of the nipple, some of the surrounding breast tissue, and they're going to draw that back as far as possible into their mouth. If a baby is just opening and coming like this, it's going to be compressing the nipple, and that is going to be painful. You'll see flatness. Sometimes it'll look like a new tube of lipstick. So what we want to do is we want to drop that baby down, let them come up and over and onto the breast, and pull that nipple far enough back in their mouth. Ideally, babies are not sucking on the nipple, they're massaging their breast tissue, and it's just squirting the milk into the back of their mouth. Um, really hard to think about where it should be. I am going to show you a video of what that looks like in a second. But if you take your tongue and you slide it all the way back on the roof of your mouth, there's a part where it becomes kind of squishy. So that's where your hard and your soft palate meet. That is where it, your nipple needs to sit in your baby's mouth in order for it to be pain-free and also in order to be efficient. So that is what we're looking for. The way we think about it is that, oftentimes, like if we go to take a drink, we drop our heads back if we're going to take a drink of something. We also, anytime we eat in general, like a lot of times we drop our head back in order and then, drop our chins in order to eat. We want to support the baby's head. And neck, obviously, but we don't want to be holding the back of their heads. We want to support sort of in between their shoulders is what we're looking for. So not the back of the head. Babies will naturally, or it's an instinct for them to push back if you push on the back of their heads. So we want to be supporting in between their shoulder blades, having our arm kind of go along their back as well. By doing this, it allows room for like their head to kind of come back. So you can kind of manipulate your baby's head here. Whereas if we're like this, we're just pushing their heads down. And then how are they going to get a wide open mouth if their heads are down like this? Again, we want to keep that nipple opposite the baby's nose and encourage them to tilt their head back. And we want them to we want their chin and their lower lip to hit first. And then we want them to come up and over. So I'm going to show you that again. So baby gets into position, drop them down, nose opposite the nipple. We want them to drop their heads back naturally. We're going to lead them in with their chin and their lower lip, and they're going to come up and over and onto the breast. And then they're going to massage that breast tissue. We're looking for a good deep latch. If a baby's like this and they have, just the nipple, that is going to hurt. So keep that in mind. If you have done that, if you followed all those steps, nose opposite nipple, dropping the head back, coming up and over, making sure that chin and the lower lip hit first, and it's still painful for you, or if you have damaged nipples, we want you to reach out for help. A poor or painful latch is often not effective, and it can certainly impede your baby's ability to transfer milk. A poor latch can also cause, nipple damage, inadequate weight gain, a reduced milk supply. So again, baby has to remove that milk in order for bodies to continue to make it. It can also lead to plugged ducts or mastitis, which is also, it's an infection in the breast. So I want to show you what this looks like, what this asymmetrical latch looks like. Sorry. There is supposed to be sound. Do you guys not hear it?
No.
I can hear it on my end. That's So if a
Recording in
baby is,
progress.
attached further back, getting that like good deep latch, then it's going to, certainly spray and they're going to get a ton more milk. And then really attaching correctly is important. So I want to show you, it's going to show you in a second what that looks like. So you can see nose opposite the nipple, and that's going to show you what this looks like. So that's a big mouthful.
You
That
can
nipple
hear
is,
it now.
yeah.
Allison. Yeah. It's weird. Like when you were talking, we could hear it, and now when you stop talking, we can't hear it.
Oh,
Hold on. Jeez.
strange.
Yeah, like when I don't understand.
Did
Now
it go away again?
Yeah.
I'll have to have them look at my settings. So I'm just going to go back and I'll pause it here so we can take a look really quickly. So what we're seeing here is that, when a baby gets a good deep latch, so if you can see this video, that baby pulls that nipple far enough back in their mouth, and then they're just compressing on the breast tissue, and that milk is going far enough back. And so that nipple is never going to be compressed. They are just, using that nipple far enough back in the mouth, they're just compressing that breast tissue. And so it's really cool because at that point, like they're just taking in like what they need. But I want to show you the opposite. So when a baby is just latching onto the nipple, so this is if they're latching on well, and then I want to show you if they're just latching onto the nipple, so not getting that good deep attachment, then we're going to see that like that is going to hurt. They are compressing that nipple, and that's going to be hitting the hard palate, and that is going to hurt a lot. So you're going to have compressed nipple. A lot of times it could sometimes look like a new tube of lipstick. So that is just something to think about. Again, we want that good deep latch. They're still getting milk, but they're not going to be getting as much milk as if they were getting that good deep latch. All right, so we're going to move on. So we're going to talk about positioning. So how can we get our babies in that perfect position to get that good deep latch? It is so incredibly important to make sure that our babies are in the right body alignment. This is a big deal. It is a game changer when it comes to positioning our babies. Just because if our babies are not in the right, body alignment, it's going to be very hard for them to latch. So the way I like to, kind of describe this is that if you and I sit down to eat, typically we are in this straight line. We will pick up, our sandwich or take our drink, and we are typically chewing and swallowing, and our bodies are in a straight line. When we feed our baby, we are also wanting to make sure that they, no matter what position that they are in, that their body is in alignment. So what we want that to look like is that we want their ear, their shoulder, and their hip to be in a straight line. That would be very similar as if we were sitting up, our ear, our shoulder, and our hips would be in a straight line. We want our babies to do the same. So the way we can think about it is that if we are holding our baby flat on their back and we're, encouraging them to turn their heads this way to feed, they are going to really be struggling to hold that breast in their mouth because they are not positioned in a way that it's going to help them, support the breast. It's going to help them. It's going to be harder for them to coordinate their suck, swallow, breathe. So what we need to do is turn our babies in. We always want our babies to be belly to belly with us, and that ear, shoulder, and hip to be in that straight line is what we're looking for. Truly, when it comes down to it, like nobody enjoys, eating or drinking with their head turned over their shoulder. So just always keep that in mind. If you guys sit down to eat, your ear, shoulders, and hips are generally in a line. We also want our baby's ear, shoulder, and hip to be in that straight line as well. We're going to go over some of the most common positions that are going to be really helpful, especially in those early days. I will point out the ones that are going to be most helpful in those early days. There are certainly other ones you can try. There is no sort of right or wrong position when it comes to feeding your baby. You are going to find what is comfortable for you and what works for you. It does not have to look perfect. Certainly, if you have lactation support, they're going to say, maybe pull that baby in closer and make sure the nose is opposite the nipple. But the most important thing is that it is comfortable for you. So I'm going to show you some of the most common positions. If you guys have anything with you, you're welcome to use like a doll or a teddy bear or a pillow or something like that. They do say that if you sort of practice this, you are more likely to be able to master the skill. So maybe even not today, but once, you are just hanging around and thinking about, latching, you can certainly try to get your, pillow or your doll or whatever into these kind of positions. So the first one I want to start with is cross cradle. So this is going to be the most common position that they're going to teach you in the hospital. It's not always the easiest on your neck or back, but it is the best for supporting your breast and the baby. So what does that look like? So in cross cradle, your baby's going to be, again, turned in towards you. That ear, shoulder, and hip are in a straight line. You're going to be supporting your baby snug to your body and supporting between their shoulder blades, hand between the shoulder blades. I would say like thumb behind one ear, and then either one or two fingers behind the other. So you can support your baby's head and neck. They are snugged really, really close into you. And then you're going to be supporting your breast like this in a C hold, either a C or a U, whatever is easiest for you, whatever position. And you're going to bring that baby up and over and onto the breast. You are supporting your baby in the arm opposite of the breast that you are feeding them from. So again, they're super, super snug belly to belly. You are supporting them with your arm, supporting between their shoulder blades, usually, thumb behind one ear, another finger or two behind the other. So you have control over their head and their neck. And then you're going to be supporting your breast with the other hand and then helping to bring the baby up and over and onto the breast. The next position I want to talk about is cradle. So cradle is very similar to cross cradle, only you are feeding in the arm. You're going to hold your baby in the arm of the breast that they're feeding on. So cross cradle is really common. Again, it's not always the most easiest on your neck and back. One of the biggest things I see when I go into homes is that, our shoulders are super high. So drop your shoulders, relax. And then you want to make sure, though, in this position, it's very easy for babies to get out of that perfect alignment. So just making sure that their ear, shoulder, and hip are in a line. But basically, a lot of times people will latch in cross cradle and then kind of slide their arm over and just hold their baby in cradle. Or certainly you can get your baby into cradle position and allow them to latch from there. Harder to kind of hold your breast in this position because they're coming on and nursing on the same breast that you're holding, of the arm that you're holding them in. But certainly it can be done. I always say this one's better for babies that have better head and neck control. So sort of once you've mastered latching, then you can, use cradle position pretty easily. And then football positions. So this one is great for if you are feeding your twins. So if you have, two babies, feeding them at the same time, this is going to be probably your go-to positioning. It is really helpful in getting babies to open up and extend their neck, especially when they're kind of wrapped around far enough where they have to come up and over and onto the breast. I can show that a little bit better, but if they're coming up and over and onto the breast. It's also great if you've had a C-section. So a lot of times with a C-section, having a baby directly over your belly is uncomfortable. So having them off to the side is going to be a little bit easier. Your baby can be in alignment either like up and down, so ear, shoulder, and hip in a line like this, or they can come from the side and also be in that position as well. So in cross cradle, again, supporting them, their feet are oftentimes wrapped around your body, and you're going to bring them up and over and onto the breast. Or sometimes they can be coming from below and come up and over and onto the breast as well. Whatever is the most comfortable for you in terms of positioning. Sometimes it, just the chair you're in can make a difference. But either coming from the side and coming over and onto the breast, or coming up and over and onto the breast is a great way to do football. And again, it's a great to latch more than one baby. So if you do have multiples, that's a great way to hold them. And then side lying position, I'm not going to show you this. I'm not going to lay down. But this is a great one, especially if you're tired. Or, sometimes babies need a lot of extra support under their bodies, and it's not support that we can give them with just their their arm, like our arms or a pillow. So in side lying, it's great to just kind of have them snuggle in next to you. And then you would just latch them. Babies that are usually bigger are better at this because they have better head and neck control. This is great for those middle of the night feedings where you kind of just slide them in and get them to latch. And then you can put them right back to wherever they are before you brought them in to feed. And then laid back position. I can kind of show you what this looks like, but more so it's just reclining back, either in your chair or on the couch or in bed or anything like that. And allowing babies to kind of come up and over and onto the breast. This is the most, I would say it's comfortable, but it also encourages your baby's like natural ability to feed. So, oftentimes babies will do a breast crawl. They'll crawl up to the breast immediately after birth and kind of self-attach. That laid back is also encouraging the same thing. Gravity is great to help keep your baby snug and on top of you and keep that wide open latch. So the weight of the baby on the breast is going to help with that. And then koala or saddle. So in this position, it involves your baby sitting upright on your leg. And then this is meant for babies that have greater head and neck control. And then, so basically their legs are on either side of your leg. This is a great one if you have like a forceful letdown. Oftentimes, if your baby has reflux, this is a great option because baby's in that upright position. Or sometimes if your baby's just getting too heavy for you to really support them in another position, this is a good one as well. I do want to show you the breast crawl. I don't believe this video has sound, or if it does, it's very little, so don't worry about that. But I want to show you, this is like the baby's natural way of attaching to the breast. So let's say you've had a natural birth, you've had no interventions. Babies are designed to do this. Now, sometimes interventions that we have during our birth can cause us to be a little bit off. Kind of messes the baby's natural ability to do this, but babies are designed to self-attach. So I want to show you what that looks like. There is no sound with this one. So this is just showing a baby that kind of got there on their own. So mama's going to unlatch. This may be uncomfortable, and she's going to allow that baby to try again. So she's going to get that baby into position as close. And you can see this baby is going to kind of bob around a little bit. They're going to be looking, oftentimes they are completely in the wrong place and they're trying to latch onto anything but the breast. But we, ideally can help them get into that position or just allow them to kind of search on their own. And babies are, again, designed to find the breast. So you can see he latched on. We can't see his nose, and that's okay. Babies will pull off if they truly cannot breathe. Babies' noses are designed to be pushed, and they can breathe out of the side of their nose, which is helpful. But you can see this baby self-attached, and he is doing really, really well there. And that's what self-attachment looks like. If you do get your baby into to self-attach and it's uncomfortable, you can unlatch them and try again. You are not like stuck in this just because your baby did it. So if it does, is uncomfortable, like we saw in the beginning of this, that mom was like, nope, we're going to unlatch and try again. And then you can get your baby to kind of come back to breast. But babies have the ability to do this on their own, providing that there are very few interventions during your labor and delivery that would sort of stop them from doing that. So you might often hear in a lot of our classes about feeding your baby on demand, or just when it comes to breastfeeding, about feeding your baby on demand. And so what we often say is watch your baby and not the clock. What this means is that a breastfed newborn will feed about 8 to 12 times in a 24-hour period, and 8 to 12 times plus, in a sense, just because it's not just set to that 12. So in the beginning, sometimes babies will feed more than that 12 times in a 24-hour period, and that's okay. Um, in the first 24 hours, we are hoping for that 8 to 12, and we want that feeding to last about 20 to 30 minutes total, and that's in that first 24 hours. Um, and then from there, again, 8 to 12 times, no less than 8 in a 24-hour period. And again, they are going to still be feeding for about 20 to 30 minutes, but after, the first couple of days, we find that babies begin to feed more efficiently. Um, the way it kind of works out when we think about it is that a baby eats about every 2 to 3 hours. And that's if we were to like evenly space out the feedings. I can tell you that newborns will not typically evenly space out their feedings. The whole idea, behind feeding on demand is when your baby starts to show you that they are hungry, we are going to feed them. And so there can be times where, your baby's a little bit less hungry and you may find that they kind of fall into that, every 2 to 3 hours. But then other times of the day, they may just be like really hungry and trying to make up for that, space that they gave during the day. So we want you to watch your baby for hunger cues and feed your baby on demand. And when they communicate that with you. So what do hunger cues look like? Oftentimes it is, your baby starting to wake up. So wherever they're going to start wake up or rousing a little bit wherever they are. Mouthing. So, kind of like putting things in their mouth or like opening their mouth. Maybe they're like smacking their lips a little bit. Sometimes you would have your baby sticking their tongue out, super cute, but that's a hunger cue. They'll often bring their hands to their mouth. Sometimes they'll suck on their hands for a couple seconds and then get mad because there's no milk coming out. A head turning and rooting. So when babies try to root, so we saw in that video, the baby was like trying to like bob around and find the nipple and was on mom's arm instead of the nipple, but babies will, turn their head or like they're frantically looking for the nipple. Oftentimes babies will like smack their lips a little bit. One of the most important things though is that crying is a late sign of hunger. The way I always think of it is that your baby is hangry at that point. So we want to try to catch those hunger cues earlier rather than later. And we want to catch them before your baby starts crying. Basically a non-crying baby is going to be easier to latch and have a better feed overall. When babies cry though, they move their tongue in a position that is not ideal for latching. So when babies cry, they pull their tongues back. And in order to have a pain-free latch, that tongue has to be out and over the lower gum line. So crying, a crying baby, we always want to calm them. Bring them to the middle of your chest, give them a second to calm down, and then try to latch them again. We don't really want to associate breastfeeding with being stressful for either one of you. So bringing a crying baby to your breast is often stressful. So we want you to calm them and then feed them. And then, how do we keep track of feeds? So truly there's no need to keep track of the number and the duration of each feed as long as your baby is growing well, gaining well, and hitting those developmental markers. We just trust that your baby is going to communicate that they are hungry, and let you know when they should feed again. If your baby though has born a little bit early, so anything earlier, so usually we say 37 weeks and less is going to be, where we're really going to be looking for, these type of things. Or if your baby had a difficult birth, maybe they're just more tired than expected. I see this oftentimes in babies that are vacuumed out or used forceps. If you're having trouble making a full milk supply, then we want you to keep track of the feeds just to make sure that everything is going well. We usually say to keep track of them, at least in the beginning, just because I know for sure that when you go to pediatrician's office, they're going to ask you how often your baby's feeding and for how long. And then also when we are, if you have a lactation consult, we often ask how many times they're eating and how long these feedings are taking us, because very long feedings can tell us something and very short feedings can tell us something as well. All right, so there are some tips for feeding on demand. So frequent feeds drives up the milk making process. So you should not let your newborn go more than 3 hours and without feeding during the day. At night, a healthy full-term baby can have one longer sleep stretch without it negatively affecting mom's milk supply. We say longer sleep stretch. This is like 4 to 5 hours, so don't get too excited. But we usually say that one is okay, especially if your baby is healthy full term. We want your baby to be in control of when the feeding stops. So you're going to be looking for things. You're going to look for relaxed hands. I call them noodle arms. You can like pick them up and they fall. Hands, so watching for relaxed hands and arms. Babies tell us a lot by their hands. So when a baby is really hungry, they have really tight fists. As the feeding goes on, oftentimes babies will completely open their hands and have them like just gently on the top of the breast. And so this is kind of their way of saying like, I was so hungry and now I'm full. A lot of times we can't get in there, and we can go in there and kind of manipulate their hands and allow us to. If babies are really hungry, they will fight us. We cannot open up their hands. So again, we're looking for those hands that are open wide and relaxed, and those noodle arms. And then we want to see if your baby is falling asleep and staying asleep. That's a good sign that things are going well. And then just a general appearance of satisfaction. So when a baby seems like they are full, then we're going to stop. I will tell you though, in the beginning, this can be really tricky because babies are really sleepy. So we want to encourage them to stay awake at the breast. This often looks like truly stripping your baby down to the diaper and making them uncomfortable in order to sustain a feed. Just because we want them to stay on there as long and get that full feeding so it can help your milk transition, and babies really driving that milk supply in the beginning. In the first couple weeks, we want you to offer both breasts at each feeding. Some babies will always take both breasts. Some will only take one per feeding. We always think of it, or at least I do, as like dinner and dessert. So oftentimes, we'll have a good dinner, but we save room for dessert. Or, other times we have a huge dinner and we're just so full that we don't want any dessert. So if you are feeding on one side, you can always try to offer the other side. It's okay if baby does not take the other side. You just want to start with that unused breast at the following feeding. We always say we want baby to finish the first side first. So babies will often spend more time on the first breast, and that is okay. And then a shorter time on the second breast. That first breast, they're, on there longer. This is going to help them get that fattier milk, the hind milk, that, usually clings to the milk ducts. And they're going to get that at the first breast. And then you're going to switch which side you start each feeding. And that's just going to make sure that the stimulation is equal between both breasts. I can tell you that, our breasts are different, and oftentimes they are not even in terms of the amount of milk that they make. I often hear like, oh, this is the one that doesn't produce a lot. We call them the slacker boob. Just because, maybe when you're pumping, you notice that you're not getting as much on that side, and that's okay. Our breasts are different. And so, one breast is always going to produce more than the other. So again, just making sure your baby's actively feeding at the breast. If they're not, strip them down, make them uncomfortable. I always kept a wet washcloth close by, or like a wet, the wet wipes type of wipes. And I would, put that on my baby's feet, tickle the feet, just kind of make them uncomfortable. We want them to stay awake so they can actually feed at breast. So when should you seek help if something's going on in terms of feeding on demand? So if your baby's only nursing for a few minutes at a time, this is a good sign that something is going on, and you should reach out for support. Just because, I've certainly seen very efficient babies, but it's pretty rare, especially in the beginning. And then if a baby is taking 45 minutes or more to finish a nursing session, this is a sign that like they're either really sleepy, or they're just not doing what they need to do. So we want to make sure that you are, keeping them awake, and then reaching out for support if a baby is feeding very quickly or if a baby is taking a very long time to feed. So these are usually two signs that something could be going on, and we want to address that. All right, so nighttime breastfeeding, what does that look like? So newborns will wake often to feed at night. I'm sorry to tell you guys that, but they do. Basically, they're trying to protect your milk supply. We want to make sure that your baby's taking in enough milk. And so a healthy term baby should not go longer than one of those 4 to 5 hour stretches at night without nursing. So that is really, really important to remember. Oftentimes, you'll hear that we want you to wake your baby to feed at night, at least until your baby has reached that 2 week mark or they're back up to their birth weight. And then at that point, we can allow them to go a little bit longer stretches. So give you that, 4 to 5 hour stretch at night. You want to respond to your baby when they're hungry. It's essential for maintaining a full milk supply. Um, Brianna is more of the sleep person than I am, but I can tell you that, breastfed babies that sleep through the night, especially from the beginning, are unicorns, and it's not usually encouraged, especially for your milk supply and to make sure that babies are getting what they need. Throughout, they need a set amount of milk during the day. So we need to, either they're really great at getting it in during the day, but it's rare for breastfed babies to sleep through the night, especially from the beginning. I think, as time goes on, maybe yes. I'm not the person to ask. My 4-year-old still does not sleep through the night. There are some safe sleep recommendations while nursing, and these are from the AAP. So basically back to sleep is what we are hearing all the time now. So babies should be placed on their back. We're looking for a firm sleep surface without soft objects. So yes, those, comforters and all those things are super cute, but there is no need for them. Room sharing for at least 6 months. This means that your baby sleeps in the same room as you for 6 months, preferably for a year. I know the number one question that comes with this usually is like, okay, but my baby will be too big for the bassinet. Yes, eventually they will be too big for the bassinet. You can move into more of like a pack and play type thing. Some people actually just set up the crib right in their room, but it is ideal for your baby to spend at least the first 6 months of life in your room, preferably a year. You also want to avoid formula. You want to avoid alcohol or illicit drug use after birth. You want to avoid overheating and head covering in infants, and you want to avoid the use of commercial devices that are inconsistent with safe sleep. So those are all the sleep, safe sleep recommendations while nursing. There are other resources. Certainly take one of our sleep classes. That would be super helpful. I know Brianna also does one-on-one sleep consults, so you can do something like that too. But these are, basically for safe sleep, the AAP makes those recommendations. So back to sleep, firm sleep surface, room sharing for at least 6 months. You want to avoid formula, avoid alcohol and illicit drug use, avoid overheating and head covering in infants, and avoid the use of commercial devices that are inconsistent with safe sleep.
I was gonna just mention something just about the sleep.
Yeah.
I kind of just like to remind everyone that, as tiring and exhausting as it can be to be, obviously feeding often during the night, I like to just mention that it really is acting as like, what's the word? Not a preventative, but, how do I want to say it? Helping you with SIDS and to not have that happen. So kind of like they're waking up to prevent that from happening, because obviously that's when it tends to happen, when we have babies sleeping too long and things like that. So it acts as kind of like what's the word I'm looking for?
I don't know. To me, it seems like a natural way to prevent SIDS.
Prevention. Yes. So I'm like, why can't I think of the word? But yeah, that's kind of how I talk about it too, just so it makes it, it kind of backs it up, a little bit, makes it feel like, okay, well then that's a really good reason too,
Yeah, for sure. All right. So how can breastfeeding suppress fertility? So Studies have shown that the average return of your menstrual cycle for a mom who is exclusively breastfeeding is about 14 to 16 months. And this is the average, guys. I have seen, so, I mean, it ranges. Some moms are getting it back, sooner rather than later. But the average is about 14 to 16 months. There are a couple different factors that can influence when your period returns or if your period returns early. So if you've weaned early, then certainly your period will return. If you are supplementing your baby with formula, it can also mean it can come back early as well. Pacifier use. And then not pumping or feeding your baby at least every 3 hours, which can happen if your baby starts sleeping through the night. So again, that 4 to 5 hour stretch in the beginning is okay. But if your baby starts sleeping longer, then it is more likely for your period to return. There are some things that do not affect when your period returns, and that is if your baby has started solids or anything to do with your diet. So many breastfeeding women will use the LAM or the lactation amenorrhea method, and this is designed to delay fertility. It is incredibly important to know that this has to be followed exactly in order, or basically exactly how it's here, in order for it to be fully effective. So your baby has to be under 6 months old. You have to be exclusively breastfeeding. Your baby must not be sleeping through the night, and your period must have not returned. And when we say exclusively breastfeeding here, we mean no bottles and no pacifiers. All of these things have to be exact in order for this to be followed correctly. And then this is a way to sort of delay your fertility. All right. So we're going to move into artificial nipples and supplementing. So the early introduction of artificial nipples can disrupt breastfeeding. So we do like to say that we would love for you to wait 4 to 6 weeks before introducing a pacifier or a bottle nipple. Really, we want to protect your milk supply, and we want to work on getting your baby to latch. So again, waiting that 4 to 6 weeks is ideal. I can tell you that this is not the case for everybody. In that middle picture there, that's my little friend. And so they let me use this to show what pace bottle feeding looked like. And, she was born a little bit early, and so was not really great at coordinating her suck, swallow, breathe, and was not willing to come to breast very often. And so we were working on a pace bottle feeding method in those first couple weeks. And then this baby went on to exclusively breastfeed. So only was given bottles when mom wanted to. So certainly if you do have to introduce, a bottle in those first couple weeks, it is not the end all be all of your breastfeeding relationship. You can certainly work really hard to get your baby back to breast. But we do, ideally want you to wait at least 4 to 6 weeks before introducing a pacifier or bottle nipple. Pacifiers oftentimes are used to sort of suppress hunger cues or delay feeding. So sometimes your baby's crying, and this could be their sign that like they were hungry and you missed all those other, cues. And then we're just giving them that pacifier to be like, okay, well, you ate an hour and a half ago. So here's this. You can't possibly be hungry. And so we're putting off those feedings. So we want to avoid a pacifier if possible. There is a pace bottle feeding technique. It is listed in our resources, so you can see that there. I encourage you to watch it. It is the best way to kind of protect breastfeeding if you are bottle feeding. It allows babies to pace the feeding at the bottle, and it's easier to go back and forth between breast and bottle if babies are not being like overwhelmed with the amount of milk that they're getting and how quickly they're getting it with a bottle. If you do have to supplement in those first couple days, if it is medically necessary, we do encourage you to use, your milk first. So either hand expressing or pumping if possible. And then if not, see if there's any donor milk that's available. It is usually screened and pasteurized and all of that good stuff. So you don't need to worry about that. And then formula would be the third option. So always ask to try to hand express or pump first. See if your hospital has donor milk, and then use formula as, the third option. We also encourage you to try to use a syringe, a cup, a spoon, or allow your baby to finger feed. Especially in those early days, if supplementation is needed, it's going to be easier to get your baby to breast if they are not used to a bottle right from the beginning. Um, it also it will help with, I don't believe in nipple confusion. Mom will always know the difference between your breast and anything else. But it, definitely flow preference. So oftentimes it's not that babies prefer bottles. It's just that they prefer the flow because they don't have to work hard at a bottle unless they're being pace bottle fed. And so babies will often be like, well, if I just get a bottle, then I don't have to work really hard and I'm getting fed. And it's harder for them to come to breast because they have to work a little bit to get that let down in the beginning. All right, so this is the pace feeding. This I noticed does not connect to the right thing, so I'm not going to share it tonight, but we do have the correct link in your resources, so you'll be able to see that. But basically what pace bottle feeding looks like is we have our babies in a more upright position, so they are up or not completely reclined, so they're in a more upright position. And then instead of having a bottle, normally for holding a baby in our arms, a bottle is like straight up and down. They don't have the ability to control the flow of this bottle. It's just they're just going to chug, 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 chug. If we put them in a more upright position and keep that bottle level, it makes it easier for them to control the flow. And so when babies will take natural pauses, we'll drop the nipple down, allow them to draw it back in. And then this is ideal to help them pace that feeding. They're working a little bit to get that. I always hear, well, what about air? The amount of air that they're truly taking in is so small, it doesn't make a difference. It's actually worse off for them to be chugging and not getting a chance to catch their breath if they are not pace bottle fed. All right, so I want to show you what hand expression looks like. This is going to be the most effective way to express that colostrum, especially in those early days. So I want to show you what this looks like. Again, colostrum is going to be super thick, sticky, and such a small volume in the beginning. So you're not going to be, hand expressing into a bottle. You're typically hand expressing into a spoon or a cup, and then you'd be feeding that to your baby. I'll be honest, most moms will continue to hand express as needed throughout the time that they are breastfeeding, especially as an alternative to using a pump. Or if your pump is just not that efficient and you can feel like your breasts are still a little bit full after, a lot of times, moms will hand express to kind of get that extra after. So I want to show you what that looks like. So with your breast, you are going to put your finger and thumb in a C shape near the edge of the areola. So everybody's areola looks different, but certainly at the edge of the areola there. And then you want to press back towards the chest wall. And then you're going to move your fingers forward and then to each other. So press back, you're going to move them to each other and then forward, and you're going to release and rotate as needed. So from the side, that's pushing back towards the chest wall and then moving your fingers forward. You're not going to roll them just to the nipple. You're going to push and you're kind of pinching your fingers together and then moving them forward a little bit. We have milk ducts through our whole entire breast. So we're not just going to keep our C in one place. This is just easier for me to do to show. But it is more like press, compress, move, and then release, press, compress, move, and then release. But we're going to move our C all over our breast and we're going to alternate our breasts going back and forth. Basically, this is, great for stimulation. You can do it before you start a feeding. You can do it after you have do a feeding as well, but you want to do it a couple times in a couple different places on one breast, and then you're going to switch to the other breast and do the same thing. You are going to notice that, the milk is going to come very slowly at first, and that is okay. Again, in those first couple days where you have that colostrum, we're not looking for large amounts of milk. It's not going to come pretty crazy, but as your baby gets bigger, if you are hand expressing, the milk could be spraying. So just keep that in mind. All right, moving on to diet and alcohol. So there are no specific dietary restrictions for breastfeeding, like at all. certainly foods can slightly flavor your milk, but it does help to expand your baby's palate for sure. So, babies that are breastfed are often better eaters, just because they can taste the difference in the things that you're eating, in your breast milk. We do say to avoid peppermint and sage, um, more like large quantities of them, or super concentrated. So, like essential oils or teas or something like that, they can decrease your milk supply. Uh, Breastfeeding can decrease your infant's risk to, becoming sensitive to allergens, especially if you're consuming them yourself. Um, some infants do have allergies. The most common are going to be like dairy, wheat, and soy. And certainly, if it's present in your milk, then you may notice some things. So, there are some signs and symptoms that we'll say to look for. So, a runny nose, especially in a baby, a really young baby, mucousy or bloody stools, projectile vomiting, any sort of rash or swelling. We can often sometimes say that elimination diets can help. So you'll start taking these things away, and see how your baby does to see if they improve. I don't recommend doing this unless you're working with a lactation consultant, just because a lot of times I see this a ton. Tongue ties are my jam. I'm not going to get into them in our class just because we don't have really a place for them. But I work very closely with other providers in the area, and often we see um, signs of like sensitivities to things. And really, or reflux, and it's really just a tie. And so then you certainly don't want to eliminate things like dairy and wheat and soy if it is a lot of what you are consuming for no reason. It's very hard to cut those things out, and you don't want to do it if you don't have to. So meeting your own nutrition needs is really important. Meeting your hydration needs is also very important. Certainly if you're malnourished or dehydrated, you're still going to make good quality milk. It's just that the quantity, so the overall amount of milk just may be reduced. So keep that in mind. Caffeine. So it is okay in moderation for most moms and babies. Typically about a 12 to 16 ounce coffee will be metabolized in about 2 hours. Some babies are not affected by the caffeine at all. For some, if you're drinking like a ton of coffee, you could see a reduction in your milk supply. It'll improve if you stop drinking caffeine. And then for some babies, like if you have a really, really fussy baby, try to cut out your caffeine and see if that helps. Sometimes babies just cannot handle the caffeine. But I've only seen this once. So it is not something that happens very often. And then alcohol. So, basically LACMED is a national database on medications and substances. And this is in regards to breastfeeding. So it states that breast milk alcohol levels are closely parallel to blood alcohol levels. So the highest alcohol levels in milk occur 30 to 60 minutes after an alcoholic beverage, but food delays the time of peak milk alcohol levels. So nursing after 1 or 2 drinks, including beer, can decrease the infant's milk intake by 20 to 23% and cause infant agitation and poor sleep patterns. Nursing or pumping within 1 hour before ingesting alcohol may slightly reduce the subsequent amounts of alcohol in breast milk. And then the CDC says alcohol from 1 drink can be detected in breast milk for about 2 to 3 hours. And then alcohol from 2 drinks can be detected for about 4 to 5 hours. And alcohol from 3 drinks can be detected for about 6 to 8 hours, and so on. So this doesn't say you can't. A lot of times what we'll say is that, have a drink immediately after breastfeeding, and then you've just bought yourself 2 to 3 hours, and then you can, feed your baby at that point. You do want to avoid other things. So any antivirals or pseudoephedrine or Sudafed. So usually anything that's like cough and, cold or congestion, anything that has a D is usually a sign of a decongestant, and it can cause your milk supply to dry up. All right, so we talked about diet and alcohol. So partner support. I always say that breastfeeding in general is a full-time job. It is also a team sport. So having someone to support you is going to be incredibly helpful. So taking care of mom is going to help her take care of baby. We want to make sure that you are eating and drinking. I always say that nobody could come to my house unless they were bringing me food. I did not want to entertain after having my kids. So certainly you can say sure, you can come hang out, but would you mind, stopping, grabbing me a tea or bring some bagels or, something like that. Um, you can certainly hold the baby while mom showers or naps. You can change and bathe the baby. That is helpful. Take on household duties that mom would normally do. So, anything like now is not the time for you to be worrying about vacuuming or doing all those other things. Um, just keep that in mind. Everyone's asking if it's The Rock. It is. It's totally staged, but it's him. So you want to arrange for additional help. So a doula, if you can, postpartum doulas are a game changer. If you can afford to hire a housekeeper, then that's a great option. It's not, an option for everybody. I know when I was having my children, I certainly could not afford a housekeeper. Um, and then family support. So, have, your mom, your sister, your in-laws, whatever, see if they can certainly, come support you and take care of the baby or, just do some things for you. Ask how you can help. This is a big one. You know, Unfortunately, a lot of times we want you to just do stuff and we don't want to have to tell you. At least I say this to my husband all the time. Um, so ask how you can help. Be like, okay, is there anything I can do for you? How can I help you? What would make this easier for you? Just find a way to do things that are going to be helpful. Um, and then most importantly, tell her she's doing a great job. Things are going to happen, cluster feeding is going to happen. There's going to be obstacles sometimes in breastfeeding. A lot of times we have a lack of confidence in our ability to breastfeed or any other doubts in terms of being a mom. So we certainly want you to reassure mom that she's doing great and encourage her. I have truly seen partners make or break breastfeeding. So just, keep that in mind. Things that could be less helpful though are we want you to avoid suggesting she offer baby a bottle or anything else unless it's medically indicated. And then avoid offering to feed the baby. I know, it's a big thing, but you can bond with your baby in like a million other ways. You do not have to feed the baby to bond. A lot of times it is well intentioned. I get it, but it's not helpful in protecting your milk supply. All right. So I'm going to try to get through these last couple slides so I can answer questions. We have a huge class today, so I want to make sure that I get to those questions. So just some recommendations for breastfeeding. So the AAP recommends you exclusively breastfeed for about 6 months. That's just breastfeeding for 6 months. And then you're going to introduce solid foods at that 6-month mark. And then you're going to continue for breastfeeding for 1 year or longer, as long as it's mutually desired by mom and baby. The World Health Organization recommends that same thing, so exclusively breastfeeding for about 6 months, and then you're going to continue breastfeeding for 2 years. Truly, what it comes down to it is that the length of breastfeeding is going to be your choice. So it is a personal decision. You're going to know what's best for you and your baby, and you're going to reach out for help. So like our goal, I always say, I never have shamed a mom for her goal when it comes to breastfeeding. A lot of consults I've done, maybe like a mix, they're wanting to introduce, formula, or they're wanting to pump and bottle feed, and that's okay. My goal as a lactation consultant is to meet you where you're at and support you in what your breastfeeding goals are. And that should be what any lactation consultant is trying to do. And then signs that breastfeeding is going well. So one of the most important things is that breastfeeding does not hurt. So you are comfortable when you are feeding. Baby is asking, so showing those cues and wanting to feed about 8 times in 24 hours. And then baby is growing well. So the average baby is going to be, gaining about 4 to 7 ounces per week. I will tell you in the beginning, babies will typically lose about 5 to 10% of their birth weight. It is expected usually in the first week of life, but then we should start to see them gaining after that 1 week, and we want them back up to their birth weight by 2 weeks of life. So we're also looking for diapers. What goes in must come out. So on day 1, we want at least 1 wet and 1 poopy. So that's thick tarry meconium. That's gonna be like that black one in the picture. On day 2, we want at least 2 wet and 1 poop. It starts to transition to a dark green or a brown. On day 3, we want 3 and 3. A lot of times at this point that it'll be more brown, green, yellow. It starts to transition. On day 4, we want at least 3 poopy diapers, and we want them to be yellow. Breastfed poop is typically it is yellow, like mustard yellow. It is thinner and it looks seedy. So by day 5, through at least 3 weeks, we want at least 6 wet, at least 3 large, so more than a quarter, and we want those to be yellow and seedy at that point. So just some quick tips for maintaining a full milk supply. So we want you to nurse on demand, not on a schedule. We want you to avoid artificial nipples if possible. So again, avoiding those, pacifiers and bottles if possible. We want to allow your baby to do all of their sucking at breast. So if we can, we avoid them. We want you to keep your baby close during the day. Certainly try baby wearing. We do have a baby wearing class. We want to keep them close so that way they feed more frequently. You're going to be able to notice their hunger cues as well, doing some skin to skin. Keep your baby close at night. So we want them to be within arm's length. So keeping that bassinet super close to them. And then prioritize feeding your baby during this very brief time that he or she is young. I can tell you that it goes by very quickly, although when you're in the thick of it, it does not feel that way. But try to enjoy it. Even if breastfeeding is a challenge, reach out for support because we can get you to a place where you actually enjoy feeding your baby. All right. We made it. We have a couple minutes left to answer some questions. So I am going to have Brianna unmute and just hit me with some questions that I can answer for you.
Ooh, my fingers are tired.
You were I mean, we had a very big class tonight. You guys have been awesome.
Yes. Holy moly.
It can be hard to get to all the questions. So I'm going to try. We have a couple minutes. I try to be respectful of everybody's time. So I don't typically go over 8:30. But I can tell you that you'll get an email from me at the end of the class, and in there you can set up a one-on-one with me if you need to. Sometimes your insurance will allow you to take the class again or something like that. So let's see what questions we have, and then we can kind of go from there.
All right. So best way to fix clogged duct and to make sure it stays unclogged. That was one.
Yeah. So it usually comes down to your baby feeding your breast. So a lot of times it has to do with a poor latch. Some people are hypersensitive and can get plugged ducts just from sleeping weird or carrying, a diaper bag on one side or something like that. There are some tips you can use to kind of get rid of that. So, getting your baby to feed is going to be the best. Sometimes heat can help with that. Dangle feeding, so like leaning over to feed your baby, is going to be helpful. Try to hand express in the shower. How can we prevent them from coming back? Really working on your baby's latch. And sometimes people will, meet with a lactation consultant and they can give some suggestions for some supplements. I know like sunflower lectin is a great preventative. It helps kind of lubricate the milk ducts. So that's something to think about.
I was just typing to someone real quick.
Yeah, somebody asked, I'll answer this one. So somebody asked, what about flat nipples? So I hate the word flat. I don't know that flat nipples truly exist. There's inverted, certainly, but I think, when it comes to, nipples that are not sticking out like this, what we want to do is really compress or sandwich the breast to give babies something to latch onto. So if we give them this to latch onto, then they're going to, again, come up and over and latch onto the breast. So you can also try to hand express or pump a little bit before to kind of pull the nipple out a little bit. But babies can latch onto anything.
Yeah, so can you put up do you have the slide that has our emails on it?
Yeah.
Can you pull up that one so people can have those so they can schedule with us directly?
Yeah.
And
And if we don't answer your question, please send us an email and I'm happy to answer any questions that you have if we did not cover them in today's class. Because again, we have a big class, so we're going to try to get to them. What other questions can I answer?
how do I know if my breast is truly empty? I feel like even when she acts like she's getting nothing, when I squeeze, there is still some.
Yeah, so our breasts are never truly empty. They are continually making milk. So yes, you could, feed your baby and then, your baby could come into breast right after and they'd still get milk. So and in the beginning, especially those first 6 weeks, our body's trying to like regulate. And so, yeah, it could feel like, that your breasts still have milk in them. The idea is that we want them to be softening the breast. Um, if you feel as though they're not, really, really emptying their breasts, we're going to keep an eye on their weight gain, keep an eye on their pees and poops just to make sure that, they're gaining well. Because in some cases, it just could be just your body trying to regulate. But we're just looking more so for like the softening of the breast and making sure baby is gaining well and watching baby's, body language when it comes to like the end of the feeding. But again, our breasts are never truly empty.
Very true, very true. What about any recommendations for moms who have a C-section and just getting the milk to start flowing and things, anything to do before the C-section?
So there's nothing you can do before a C-section, but the same thing is true after, a vaginal birth. So tons of skin to skin and just feeding as often as possible. Really latching that baby as many times as possible is going to be ideal. Sometimes we see a delay in milk coming in after a C-section, but that's not always the case at all. So just, bringing that baby to breast as often as possible, doing as much skin to skin as possible is going to be ideal after a C-section.
And can you talk a little bit about when, and you may have, but like just when to start pumping,
Yeah.
or when you can,
Mhm.
or how often after the
Yep.
feedings can you do that?
So, we do have a pumping 101 class and it kind of walks you through like all of that. But certainly, let's say, you're starting to head back to work. We really don't want you to be doing any of that for at least like the first 4 to 6 weeks, if possible. But understandably, that is not the case for everybody. So certainly if you are having to supplement, so if your baby's getting a bottle, um, you either need to hand express or start pumping in order to stimulate. So anytime a baby is supplemented, so they're getting milk from anywhere but at the breast, you have to be hand expressing or pumping to protect your supply. So sometimes that looks differently in the beginning, depending on how well your baby latches or anything like that. So you can certainly start early. When you're like, okay, everything's going well with breastfeeding, I want to start storing milk or creating a stash. You're going to pump once a day. First thing in the morning after you like immediately after you feed your baby, you'll pump both breasts for about 10 to 15 minutes and you're going to just start storing that milk. We're not looking for large quantities of milk. We're just looking for a way to start a stash.
Let's see. And lastly, when you hand express, what are you expressing into?
Anything. So you
Like
can
a
express into like
breaded-
a bottle, into a cup, into a spoon. In the beginning, like we'll usually say like, sorry, like a little medicine cup in the hospital or a spoon. As time goes on, your milk transitions, you can hand express into a bottle. Usually a wide mouth bottle is going to be more better to, it's just gonna be easier to get the milk to go into there, but you can hand express into anything.
Will the lamb method still work if both breastfeeding and pumping?
I don't believe it does. I think you have to be feeding directly at breast.
Right. I think it's
I saw one about unlatching. It is important to learn how to unlatch. You don't want to just pull your baby away. Usually you want to get into the corner of their mouth and break the seal, or you can pull down on their chin. You want to get in between their gums. My husband said it's kind of like fish hooking. So like I used to make like a, kind of like a fish hook with my finger and get into my baby's mouth and just break the seal that way. You never just want to pull a baby away. They'll stay attached. So you want to get in there and just break the seal in between their gums. You can pull down on their chin, it'll break the seal, and then you want to move your breast away from them. Certainly don't want to rip your nipple off.
yeah, they have really good suction.
Yeah.
And then the last one, if your milk isn't coming in at first, is that when formula is recommended, or what do you do in the interim?
Yeah, so I mean, we all have colostrum, and again, that's all your baby needs in the beginning. Sometimes, yes, you may have to supplement. Again, we want to see if your hospital has donor milk first, and then you would be hand expressing or pumping, and then if not, then they may recommend formula. But I can tell you that supplementing is not the end all be all of your breastfeeding relationship. So if you have to do that, you want to be working closely with a lactation consultant to try to get your baby to breast. So that way you can be successful if breastfeeding is what you're wanting to do.
Awesome. That's about it. I think we got them all, but like she said, if like Allison
Yeah.
said, if you didn't, you can totally message or email us directly.
Yeah, for sure. So again, this is a really big class. I know Brianna's been going crazy answering all the
Mhm.
questions. Like I mentioned, my email's up on the screen, so is Brianna's. I will send you an email a little bit later. And then it'll have our breastfeeding resources in it, as well as it'll have, my email. Brianna will also be in there as well. And then you will, if you want to set up a one-on-one or if you have any questions, just respond to me directly and let me know. And I can try to get you onto my calendar. I know I'm pretty booked out right now. I don't know what you look like, Brianna, but I'm going to try to open up more spots just so I can be fair and I can get everybody in. But thank you all for joining me. I hope to see you guys in one of my other classes, or find Brianna in one of her sleep classes. Any of those classes, again, can be done as a one-on-one, so certainly reach out. And I hope you guys enjoy your night, and I hope you're all very successful in breastfeeding.
Bye, guys.